The phase 1 Venetoclax study in relapsed and refractory chronic lymphocytic leukemia demonstrated excellent overall response rates. These were deepened further in the phase 1b study combining Venetoclax together with rituximab, with high rates of CR, complete remission, and high rates of undetectable MRD at 61%. These responses were durable. However, looking at survival curves with reasonable periods of follow-up, relapses still occurred. Our group sought to ask the question, could MRD status be used to predict and prevent these relapses from occurring? Our data suggests that undetectable MRD should be the goal of therapy in patients with relapsed and refractory leukemia treated with Venetoclax. And this is on the basis of our retrospective study of 62 patients treated at our sites, the Royal Melbourne and MacCallum Cancer Centres, between the periods of 2011 and 2018, our data cutoff. We incorporated patients from 3 clinical trials in the early phases, 36 patients from the first in human Venetoclax study in relapsed and refractory CLL, 14 patients from the phase 1b study combining Venetoclax and rituximab, and 12 patients from the Venetoclax study for deletion 17p. And what we found was that there were firstly strong correlates between peripheral blood and bone marrow undetectable MRD status to the sensitivity of 10 to the negative 4. We've further found that the median time to detection of undetectable MRD was 18 months. In fact, 90% of patients who were to achieve MRD did so at 24-month mark. Furthermore, the time, using this as a time point for a landmark analysis, we found that there was superior time to progression in patients who had undetectable MRD in both their peripheral blood and bone marrow compartments. The results were comparable compared to those patients who were MRD positive in either of those compartments. Unfortunately, despite attaining undetectable MRD in 26 of our 62 patient cohort and their increased time to progression, MRD recrudescence did occur. This occurred at a median time of 46 months in these patients, and looking at subgroups, occurred more rapidly in those patients with TP53 dysfunction, that is, mutations of TP53 or deletion 17p. And so we feel that given there is a strong correlation with improved time to progression, that the 24-month mark should be the goal of undetectable MRD attainment. We feel that despite the undetectable MRD being attained, because of recrudescence occurring, that we need to work towards more potent combinations in the future to achieve deeper responses and more durable responses. Certainly we would like to evaluate this question further by looking at whether deeper sensitivity MRD testing will further separate out the patients who perform better with more durable responses. For example, looking at flow cytometric MRD evaluation at a sensitivity of 10 to the negative 5. And certainly it would be interesting to see all the trials that come out looking at MRD prospectively as opposed to our retrospective analysis to see how this bears out in a randomized fashion.